Okay, guys, so today we are going to talk about another endocrine gland, which is the thyroid gland. Uh, and we would talk as we usually do. We'll start with the gross anatomy of the thyroid gland. Then we are going to move on and talk about a little bit of the histology of the thyroid gland, how the thyroid hormone is synthesized, how it is regulated, uh, and then some of the functions of the thyroid hormones, what are the functions, and then we end up with hyper and hyposecretion of the thyroid hormones. So let me begin with the thyroid gland. Thyroid gland is a Greek word, and it came from a Greek word which is called thyrios. Thyrios means a shield, because if you see the thyroid gland in the neck, it is covering your trachea and esophagus. Here it's like a shield made up of, it's just looks like a shield covering your trachea and the esophagus. So we are going to talk about the shape of the thyroid gland, location, extent, parts of the thyroid gland, capsules. We would talk about how we examine an enlargement or a goiter in the thyroid gland. And then we are going to talk about some of these, arterial supply, which is very important here in thyroid as such. So we start with the thyroid gland. We would see that thyroid gland is a brownish red soft structure, which is, you can see in this picture. It's around 25 to 30 grams larger in women as compared to the males. It has an external capsule, which is the false capsule. It's basically covering the thyroid and attaching it to the trachea, which is called the pretracheal fascia. And then it has a true capsule which covers the gland itself. So why this false capsule is important? Because it is covering the thyroid gland and attaching it to the trachea. It's a pretracheal fascia. So if there is any enlargement in the thyroid gland, what is going to happen is that when you ask the patient to swallow anything, so you know that during swallowing, the trachea and the larynx move up. So you ask the patient to drink a sip of water and observe this enlargement. If it is moving up and down with swallowing, this means that this is a thyroid enlargement or thyroid goiter. So the importance of the pretracheal fascia is that it is covering the thyroid gland and attaching it to the trachea. So when the trachea and the larynx is going to move up during swallowing, the thyroid is going to move up and down with it. There are two lobes of the thyroid gland, right and the left lobes. They are connected with each other by this small area which is called the isthmus. Sometimes you also have this another lobe which is called the pyramidal lobe, and this happens in 10% of the people. Not everybody has this pyramidal lobe. So you have right and left lobes, and they are joined together by this small area which is called the isthmus, and sometimes from the isthmus you can see another lobe which is called the pyramidal lobe. Now where you are going to find this thyroid gland? So what you can see is that you can pulsate your carotids here. Okay, so your carotids are the lateral margin of the thyroid. The Adam's apple, which you see here, is the place just above this on the side is the upper pole. And if you are going to count the tracheal rings, the lowermost pole of the thyroid gland is around the 6th tracheal ring. So if you start to count the tracheal rings from the cricoid cartilage, it is going to be the 6th tracheal ring where you would find the lower pole. So the upper pole is somewhere in the mid of the thyroid cartilage, and the lower pole is at the level of the 6th tracheal ring. And the sides could be margined by the carotid arteries. So here you can see that the thyroid gland is completely covering the trachea and the esophagus. And anteriorly, if you want to expose this thyroid gland, you need to take out these strap muscles. And these strap muscles are sternohyoid and sternothyroid. So you need to, clear these strap muscles to reach to the thyroid gland. So anteriorly, strap muscles, the sternothyroid and sternohyoid are covering. On the sides, you would see that the thyroid gland is covering the trachea and the esophagus, and to the lateral margin, you would have the internal carotid arteries and the internal jugular vein, which are going to be at the lateral margins of this gland. So you can see it here. This is the lateral margin of the gland. You can see the internal carotid and the jugular vein, internal jugular vein and the common carotid arteries are basically at the lateral margin. The posterior surface of the gland is covering the trachea and the esophagus. Anteriorly, the gland is covered by sternohyoid and the sternothyroid muscle. Each lobe is pear-shaped, about 5 centimeter long, extend inferiorly on each side of the trachea, and often reaches up to the level of the 6th tracheal ring. So if you see the lower pole, it would be somewhere around the 6th tracheal ring. Attached to the arch of the cricoid cartilage and the oblique line. So if you see the upper pole, it is on the oblique line of the thyroid cartilage and the cricoid cartilage, where the upper pole of the thyroid gland is attached. And when you are going, because it is covered by the pretracheal fascia, this is going to attach it to the trachea. When you swallow, it is going to move up and down with the trachea. The arterial supply of the thyroid gland is one of the most important things which you need to know in terms of the anatomy, gross anatomy of the thyroid gland. A lot of questions which you are going to get are going to be related to the arterial supply of the thyroid gland. Why it is important? Because majority of times when you have a big thyroid gland or a cancer or something, or tumor there, you need to do surgery and remove the thyroid gland. When you are removing the thyroid gland, it is called thyroidectomy. And you need to clamp the arteries. So you need to clamp the arteries before you can remove the gland. So the first artery which supplies the thyroid gland is this artery, which is called the superior thyroid artery. Superior thyroid artery is the first branch of the external carotid. Common carotid divides into external and internal carotid. So from the external carotid, you have this artery arising, which is called the superior thyroid artery, and it goes to the upper pole of the gland and then divide into an anterior branch and a posterior branch, which supplies the anterior and posterior surface of the gland. The other important artery, which is which is supplying the thyroid gland, is the inferior thyroid artery, and this is a branch of the thyrocervical trunk. You know the subclavian? Subclavian gives this thyrocervical trunk, and this thyrocervical trunk gives this artery, which is the inferior thyroid artery. It passes behind the internal jugular and internal carotid, reach the groove between the trachea and the esophagus just below that. Before that, it supplies the lower pole of the thyroid gland. So what is that? Why this is so significant? There are two arteries, superior thyroid, inferior thyroid, one coming from external carotid, the other is coming from thyrocervical trunk. So what is unique here? The unique here is that at the origin of the superior thyroid artery, it is very close to a branch of vagus, which is called the external laryngeal nerve. It is very close to a nerve, which is called external laryngeal nerve. So if you try to ligate the superior thyroid artery at its origin, where it is very close to the external laryngeal nerve, you can tie the external laryngeal nerve with the artery. So what would happen? It supplies one muscle, which is called the cricothyroid muscle, and it is important for making the vocal cord stretched. So if this muscle is paralyzed because external laryngeal nerve is gone, then there would be bowing of the vocal cords. So the quality of your voice will change because you cannot produce high frequency sound. High frequency sound, you need your vocal cords to be stretched. So this external laryngeal nerve supplies this cricothyroid muscle, which makes the vocal cord stretched, and this will result in bowing of the vocal cord. So what you do is that you, rather than tying the superior thyroid artery at its origin, you tie the superior thyroid artery near the upper pole of the thyroid gland. So that's how you save the external laryngeal nerve. Now the other artery, which is the inferior thyroid artery, is going to the lower pole. And you have heard about another nerve, which is called the recurrent laryngeal nerve. And recurrent laryngeal nerve is running in the groove between trachea and the esophagus to reach the larynx. And this nerve supplies all the muscles which move the vocal cord. So if you tie the artery close to the gland, there are chances that you are going to tie the recurrent laryngeal nerve, which will paralyze the vocal cords. And if it is going to be paralyzed, then you would have hoarseness of voice if it is one vocal cord. And if both vocal cords are affected, then there would be, you would stop breathing also because vocal cords will come in the center and you would have difficulty in breathing and you would not be able to produce voice. So that's why it is important to tie the inferior thyroid artery away from the gland. Because if you tie away from the gland, there are no chances of tying the recurrent laryngeal. The other important thing is that before doing a thyroid surgery, you do a laryngoscope exam and see the movement of the vocal cord. Because you should not be blamed after surgery that you damaged these nerves. So you want to ensure that the vocal cords were moving before the surgery. Okay? So this is the importance of these two arteries, the superior thyroid and the inferior thyroid. In 10% of the patients, you might have another artery which is called the thyroidema artery, which arises from the arch of aorta and goes directly to the isthmus. So it is running on the tracheal rings and it is going all the way to the isthmus of the thyroid gland. This happens in 10% of the people. Thyroidema artery is present, which arises from the arch of aorta. Now, importance of that artery. In some cases, we do tracheostomy. We make a hole in the trachea and we put up, these the tube here so that they can breathe. If they have an obstruction in the upper part of the airway, we do a tracheostomy, make a hole in the trachea and put an endotracheal tube here so that they can breathe. Now when you are doing a tracheostomy, you should be aware that there is a chance that there is a thyroidema artery, and if you make a hole here and you damage the thyroidema artery, that would cause a lot of bleeding. So that is also something which is important and you should know about. So you have this superior thyroid artery, which is a branch of external carotid, and we have talked about it. And then we have the inferior thyroid artery, which supplies the lower pole. And in 10% of the people, we have this thyroidema artery, which arises from the arch of aorta or brachiocephalic trunk. And we need to know that this artery is present in 10% of the people, because if you damage it during making a hole in the trachea or tracheostomy doing, and this would result in a lot of bleeding. Yes, go ahead.
What does ICA stand for?
Internal carotid artery. So you can see the relationship here. See, this is the superior thyroid artery, and look at the relationship of the external laryngeal nerve, or which is a branch of the superior laryngeal. So this nerve is in very close proximity at the origin of the artery. You see this one, this is the inferior thyroid artery. You see this is very in close proximity to the, near the gland, it is very close proximity to the recurrent laryngeal. So you need to tie this off at its origin rather than close to the gland. Superior thyroid, you tie close to the gland. You don't tie it at its origin. There are three pairs of veins which drain the thyroid gland or the venous plexus on the anterior surface of the thyroid. The superior thyroid veins which drain the superior poles, the middle thyroid vein which drains the lateral part of the gland, and superior middle thyroid veins empty into the internal jugular vein, while the inferior thyroid vein, which drains the inferior pole, empties into the brachiocephalic vein. So you have three veins. You have two arteries mainly, but three veins, superior, middle, and inferior. Superior and middle opens up into the internal jugular vein, while the inferior one opens up into the brachiocephalic vein. Lymphatics. Lymphatics are present in the interlobular connective tissue. So there is inside the connective tissue of the lobes of the thyroid gland, there is lymphatics which are running. They communicate with the capsular network of the lymph nodes. They pass first to the prelaryngeal group, then to pretracheal, then to paratracheal. So prelaryngeal in front of the larynx, pretracheal in front of the trachea, and then they go to paratracheal group, and from that the paratracheal group they go to the superior cervical group, deep cervical group of lymph nodes, and ultimately they drain into the brachiocephalic group of lymph nodes. Why these lymph nodes are important? If you have a thyroid cancer, the nodes which you are going to look for, the lymphatics which you are going to, lymph nodes which you are going to look for are prelaryngeal, pretracheal, paratracheal, and deep cervical group of lymph nodes. Now let's move on and look at a little bit of the internal structure of the thyroid gland. So we know that the thyroid gland is covered by a connective tissue layer, and this connective tissue layer is also holding posteriorly to another endocrine gland, which is called the parathyroid gland. So parathyroid gland is present in the dense connective tissue behind the thyroid gland. So behind the thyroid gland you have these two superior, two inferior parathyroid glands. And parathyroid glands we would not discuss in detail today. We used to do parathyroid in the endocrine, but now we are going to do parathyroid with the MSK block because it is mainly related with calcium metabolism. So parathyroid gland secretes a hormone which is called the parathyroid hormone, and that parathyroid hormone is important for increasing the blood calcium levels. That's all what I'm going to say today, because the details of parathyroid you are going to deal with the MSK block. Now, the capsule of the thyroid gland is going to send septas inside the thyroid gland and divide the thyroid gland into follicles. These septas will also serve as conduits where the blood vessels and lymphatics and the nerves are also going to travel. I'll show you in a minute. So you see these septas, can you see these? These are the connective tissue septas which are being sent from the capsule to divide the whole gland into lobules, small lobules, and within the lobules you are going to see these follicles. Can you see these? The whole thing is basically having several lobules, and within the lobules you are seeing these follicles. Now these follicles are single layer of cuboidal epithelium. So you would have single layer of cuboidal, so you're looking at it because you are seeing a cross section. But if you would see in actual form, they would be follicles like this. Follicles, follicles, follicles. And within the follicle, you have this colloid or thyroglobulin which is there. So you have a single layer of epithelium, and inside what you are seeing, this pink thing, is basically colloid collection, which is thyroglobulin, from where the thyroid hormones are going to be synthesized. So you have a single layer of epithelium, inside it is thyroglobulin or the colloid which is there. So what you are seeing here in this histological section, you have these septas which are going to divide. You have lobes, but within the lobes you would have lobules which are formed by the connective tissue septas which are coming from the capsule. And within the lobules you would see these thyroid follicles. Thyroid follicles are single layer of squamous or cuboidal epithelium, and inside these follicles you would see thyroglobulin or the colloid, which is basically stored from where the thyroid hormones are being formed. So thyroid follicles are spherical structures filled with colloid, a viscous gel containing mostly iodinated thyroglobulin. Thyroid follicles are enveloped by a layer of epithelial cells called follicular cells, which are usually either cuboidal or squamous, which in turn is surrounded by another set of cells which are called parafollicular cells. Now these parafollicular cells secrete not thyroid hormones. They secrete another hormone which is calcitonin, which is again also important in calcium metabolism. It actually lowers the blood calcium level. These two parenchymal cells rest on the basal lamina, which separates them from the abundant networks of capillaries. The function of the thyroid follicles is to synthesize and store thyroid hormones. You can see it again. This is a lobule, and which is formed by the septas of the connective tissue, and within the lobule you see these follicles. These follicles have thyroglobulin inside them, and they are lined by a single layer of squamous or cuboidal epithelium. Simple cuboidal epithelium, it is only one of the sites, because they are very rare sites where you would find simple cuboidal epithelium. Simple cuboidal epithelium is present, which lines the thyroid follicles. Now follicular cells are normally cuboidal in shape, but they become columnar if they become stimulated, and then they can become flattened if they become inactive. So if thyroid follicle is very active producing the hormone, the cuboidal cell will become columnar, and when it is inactive, they would become squamous. So follicular cells may contain many apical vesicles, which you can see here, which is involved in the transport and the release of thyroglobulin. You can see it here. Inactive thyroid follicle, you have squamous type of cells. There is a lot of thyroglobulin which is inside it, and this is an active follicle where the cells are becoming more cuboidal, and there's less amount of thyroglobulin inside. So this is how you can differentiate between an active thyroid follicle versus an inactive thyroid follicle. Now there are two hormones which are basically secreted by the thyroid gland. One is the thyroxine, and the other is the triiodothyronine, or T3. If you see this thyroxine molecule, it is also called tetraiodothyronine because it has 1, 2, 3, 4 atoms of iodine which are attached to a tyrosine molecule. If you see this, a tyrosine molecule is attached with 3 iodine molecules, so that is called triiodothyronine or T3. This is T4, which is the major hormones of the thyroid gland. So 7% of the total production of the thyroid gland is T3, and 93% of the hormone which is produced by the thyroid gland is thyroxine. T3 and T4 are equally qualitative but differ in their rapidity and intensity. For example, T3 is 4 times more potent as T4 but less present in the blood, and T4 is going to be present for a longer period of time. So T3 has a very short half-life, but it is 4 times more potent as T4. Now we are going to discuss, the synthesis of the thyroid hormones, and this is also something which is very high yield. People are going to ask you about the synthesis physiology. People are also going to, talk about the synthesis. So the first step is to form the thyroglobulin, which is going to be produced from tyrosine. And this thyroglobulin has to be, pushed into the lumen of the follicle where it is going to be stored. The second step of this is that this thyroglobulin needs to be iodinated. So you have a sodium iodine pump, which is going to push the iodine or iodide in your blood into the follicular cells. Once iodide is in the follicular cell, it needs to be converted from iodide to iodine. So on the lumen of your or the apical area of your thyroid follicle, you have this enzyme which is the thyroid peroxidase, which will convert the iodide to iodine. Next, this peroxidase is going to add iodine into the thyroglobulin molecule. And how, if it is going to add one iodine, it would make monoiodotyrosine. If it is going to add two tyrosine molecules, then it will make diiodotyrosine. And the third step which the peroxidase do, it actually combines either a monoiodine tyrosine with a diiodotyrosine, which is called the coupling step. So the coupling would result in formation of T3 or T4, because if two molecules of DIT combine, then it would be T4. And if monoiodotyrosine is going to combine with DIT, you would have triiodotyrosine, which is going to be formed. So you would have coupling step also done by peroxidase, which will result in the formation of T4, T3, and also you have monoaminotyrosine and iodotyrosine. So when you have a stimulus from the TSH, because you have the pituitary gland, which is basically asking that when you need thyroxine or when you need, thyroid hormone, when TSH will come and bind here to the thyroid follicular cells, what would happen? There would be endocytosis. There would be, these pseudopods from the apical surface of the follicular cells will go into the thyroid follicle, and it would take these T4, T3 inside the cells. When it would take it inside the cells, you have lysosomes which are going to bind to these vesicles, which are basically taking the T4, T3 inside, and it is going to release T4 and T3 into the circulation. And then you have deiodinase, which are going to take out the iodine from the DIT and MIT. That would produce again the thyroglobulin, which will recycle inside the into the follicle. So this is how the thyroid hormones are synthesized and released. We can see it here, the synthesis of thyroglobulin and extrusion into the follicular lumen. This is through the rough endoplasmic reticulum and the Golgi apparatus of the thyroid follicular cells. Then you have the sodium iodide cotransport, which is present at the basal membrane. This would actually put iodide into the cells. Then you have oxidation of iodide to iodine. This happens at the apical membrane by the peroxidase. Then you have the organization of iodine to the thyroglobulin, which is going to organification of the iodine to the thyroglobulin, which will produce MIT and DIT. Then you have a coupling reaction, which will create T3 and T4. Then endocytosis of this thyroglobulin when you have TSH coming, hydrolysis of T4, T3 by the lysosomes, and then release of T4, T3. And the rest of the MIT and DIT are recycled for iodide and for the production of tyrosine, which is required for thyroglobulin synthesis. Anybody has any problems with this? Yes, go ahead.
Step 6, endocytosis of T3.
Yes.
It's done by TSH.
So it would, the cell, how would the cell would start doing the endocytosis or produce the hormones? It is under the action of TSH. So when the TSH will come, bind to the receptor on the follicular cells, it will stimulate the follicular cells to send endocytos, the thyroglobulin, pull it in, lysosomes will attach, release the T3, T4, and the rest of the MIT and DIT would be deiodinized to produce tyrosine as well as iodine. Because you do not have enough iodide in the circulation. So you need this thyroid deiodinase to keep on making thyroglobulin. Otherwise you would have a problem with the formation of thyroglobulin. Yes?
So the Mo and Di are with the T3 and T4 or they separate?
So lysosomes will chop off. So T3, T4 will go into the circulation. MIT and DIT would be recycled by the deiodinase. Deiodinase will remove the iodine and remove the tyrosine. Tyrosine will be used for making thyroglobulin. Iodine is going to be recycled also to be used to iodinize the thyroglobulin in the follicular cells.
So they're only going to separate the Mo and Di that will give them.
Yes. Yeah. Yeah, go ahead.
So both DITs combine to form T4?
Sorry?
Both DITs, they
Yes, when they are going to combine two DITs, it is going to give rise to T4.
And those are part of thyroglobulin?
Yes.
The MIT and DIT?
Yeah, yeah. Thyroglobulin is basically a large set of tyrosine molecules. You know, you have tyrosine, 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 tyrosine. If you are going to have large group of tyrosine molecules attached to each other, that is going to give you thyroglobulin. Now you iodinize thyroglobulin, that is going to give you MIT. If you add two iodine group to a tyrosine molecule, this will give you DIT. And if you have coupling of monoiodotyrosine with DIT, you get T3. And if you have DIT coupled, then you have T4. Now, once this is produced and you have a signal from the anterior pituitary, you endocytose this thyroglobulin inside the cell, lysosomes will attach to it, will separate MIT, DIT, T3, T4. T3, T4 go into the circulation. MIT and DIT are going to be deiodinized to iodine and tyrosine, which is going to be used to form another set of thyroglobulin to be secreted into the follicular cavity.
And T3 and T4 are hormones, right?
Yeah, they are the hormones. So this is the steps of the formation again. You have the thyroglobulin produced, which is going into the follicular lumen. It gets oxidized. The iodide which you are basically taking in needs to be oxidized to iodine. Then you do the organification of the thyroglobulin, that means formation of MIT, DIT. And then MIT and DIT are going to have a coupling reaction, and this coupling reaction results in the formation of MIT, DIT, T3 and T4. Then you have the endocytosis, these proteases in the lysosomes are going to chop this off. The T3, T4 would go into the circulation. MIT and DIT would be deiodinized to give more of thyroglobulin as well as the iodide which is needed there. Then what you need to know is that we have certain drugs, because you can have a condition which is called hyperthyroidism. So you need to decrease the synthesis of thyroid hormone. So these drugs, propylthiouracil and methimazole, they actually are inhibitors of thyroid peroxidase. So because they inhibit thyroid peroxidase, so they are going to stop the synthesis of thyroid hormone. So they are given in hyperthyroidism. If you have overactivity of the thyroid gland and you are producing too much of thyroxine, you can give propylthiouracil or methimazole, they are going to both block the thyroid peroxide. Now, when the hormone goes into the circulation, the active form of the hormone which affects the cell is T3. So it needs to be converted. T4, which is the most abundant hormone, among the thyroid hormone, which is secreted the most, 93% of it is T4. So, but the active form which can affect the tissues is T3. So in the tissues, you have 5' deiodinase, which is going to change the T4 to T3. But this tissue deiodinase is different from the thyroid deiodinase. So tissues have their own deiodinase, which is called the tissue deiodinase, which will convert the T4 to T3, which is the active form of the hormone. So active form of the hormone is T3. It has to be converted back into T3 from T4, which is the most abundant of the thyroid hormone, to become active. Again, this tissue deiodinase can also be inhibited by propylthiouracil. So propylthiouracil is a very potent drug. Not only it can block thyroid peroxidase, but it can also block the tissue deiodinase. So you would not be able to convert the T4 to active T3, which is going to act in the tissues. Everybody clear about this? Now we are coming to the regulation. So the regulation is simple. We have hypothalamus, which release thyroid releasing hormone. This activates the anterior pituitary, which is going to release the thyroid stimulating hormone. This thyroid stimulating hormone acts on the thyroid follicular cells and releases T3 and T4. Now, if you have too much of T3, T4, then you have a negative feedback. And this negative feedback can be to the pituitary, and this can be to the hypothalamus. So whenever you have high levels of T3 and T4 or hyperthyroidism, your TSH levels will be low and your TRH levels will be low. When you have hypothyroidism, that means your thyroxine levels are low or T3, T4 levels are low, you would have higher levels of TSH and higher levels of TRH. So this is an opposite relationship. Somebody can trick you very easily and give you that TSH is high. When TSH is high, this means hypothyroidism, because the anterior pituitary is trying to push the thyroid glands to produce more thyroxine.
Doctor,
Yes.
I don't know if it's hypo or hyper. Because it is-
Sorry?
I don't know if it's hypo or hyper because of TSH.
Yeah, so TSH is coming from the pituitary. When you have low levels of T3, T4, which is hypothyroidism, the pituitary would push the thyroid gland to produce more hormones. So your TSH levels will go up, your TRH levels will go up. If you have hyperthyroidism, that means there's too much of the thyroid hormones, then your TSH levels will be low, your TRH levels will be low. The other important thing which you should know is this antibody. So we have several. Yeah, go ahead, please. So hypothyroidism can be happening, hypo or hyper. Okay, hypothyroidism can happen because of a problem with the thyroid gland itself, and can also happen because of a problem in the pituitary. Primary hypothyroidism will happen because of a problem in the thyroid gland. There is an autoimmune destruction of the thyroid gland that can result in hypothyroidism. There is iodine deficiency. You cannot make enough thyroid hormones, because if you have iodine deficiency, that is also going to cause hypothyroidism. Hyperthyroidism can happen because of something which I was just going to tell you. There is an autoimmune disease and you are producing an antibody which is called thyroid stimulating immunoglobulin. So it has the same structure as TSH. So what is happening? The TSI, which is an antibody, it's an auto-antibody. It happens in a disease which we call as Graves' disease. You have this antibody produced by your body, which is called thyroid stimulating immunoglobulin. And this thyroid stimulating immunoglobulin has a structure like TSH. So it will go and bind to the follicle like TSH, stimulate the thyroid hormone production. So you would have hyperthyroidism.
Weight loss.
Yeah, weight loss will happen because of hyperthyroidism. So we are just talking about regulation at this point of time. So what the most important concept here is that when you have hyperthyroidism, TSH will be low, TRH will be low. When you have hypothyroidism, you have more TSH, you have more TRH. Yes.
Is there a feedback inhibition for TSI?
Feedback inhibition for TSH is there. You see this?
Yes.
No, immunoglobulin is an auto-antibody. There is no feedback inhibition. It's basically produced by your body. It's an antibody which is produced by your body because of a disease. Okay? But it has a structure similar to TSH. So it goes and binds to the TSH receptor and the body is thinking that TSH is coming. So you are producing more thyroid hormone. Okay? Everybody clear about this? Regulation. Now we are coming to the functions of the thyroid hormones. So only free hormone is active and T3 binds to the nuclear receptor. So T3 goes inside the tissues and binds to the nuclear receptors. It does not bind to the surface receptors or cytoplasmic receptor. It binds to the nuclear receptor. And it is the most active form of the hormone. So the tissues need to have tissue iodinases to convert T4 to T3, and this T3 would have these 6 functions. You know that the brain is an organ which keeps on developing after birth also. So it has, the thyroxine has an important function in brain maturation. That's why when the child is born, right after birth, you check the thyroxine levels because it is important for maturation of the brain. If you have, the child has low levels of thyroxine and you don't replace it, it would result in a condition called cretinism, which is the mental retardation, which has mental retardation. So you need to know that the thyroxine is very important for brain maturation, and right after birth, we basically check the levels of thyroxine. It is important in bone growth. So it is a synergistic action with growth hormone. It affects the beta adrenergic receptors. So it increases the beta 1 receptors in the heart. So it increases the heart rate, cardiac output, the stroke volume, contractility. All this happens because of its effect on the beta adrenergic receptors. It increases the basal metabolic rate of all the cells because it increases the sodium potassium ATPase activity. That's why you would generate more heat because of the overactivity of thyroxine. So thyroxine increases the basal metabolic rate of all cells, all tissues in the cells. It is important because it increases the activity of the sodium potassium ATPase activity. Blood sugar, it causes glycogenolysis, that means break down the glycogen, and it also makes new sugar through gluconeogenesis. And it also does the breakdown of the lipids. So what it is doing, it's a totally catabolic hormone. It is breaking down the carbohydrates, it is making more glucose from the non-carbohydrate source, it is breaking down the lipids, it is breaking down the proteins. So it is a catabolic hormone. It's going to, so if you have too much of thyroxine, you would start to lose weight because it is doing catabolism of proteins, fats, and it is producing glucose so that you have energy because it is increasing the basal metabolic rate. Clear, everybody? These are the functions of the thyroid hormones. I would not go into details. Physiology people are going to discuss detailed functions of the thyroid hormone. Now, the diseases of the thyroid, gland. You can have hyperthyroidism, which is caused by either a toxic goiter. What we mean by toxic goiter? Goiter is an enlargement of the thyroid gland. If you have an enlargement of the thyroid gland, that is called the goiter. If there is a lobule here which is producing too much of the thyroid hormone, that is called the toxic goiter because it would be an enlargement of the thyroid gland, but this lobule is producing too much of the thyroid hormone. You may have a disease which is called the Graves' disease, which these guys are going to keep on asking you. Graves' disease is an autoimmune disease. That means it is producing autoantibodies. What type of antibodies are produced? Thyroid stimulating immunoglobulin. Now this thyroid stimulating immunoglobulin has a similar structure as the TSH. So it is going to bind to the TSH receptor, induce continual activation of cyclic AMP system, and it is going to produce a lot of thyroid hormone. You can have a thyroid adenoma, and it is producing, too much of thyroid hormone. That can also result in hyperthyroidism. So what would be the symptoms of hyperthyroidism? You said the basal metabolic rate is going to go up. The heart rate is going to go up. So there would be high state of excitability because it affects the brain. And we said that it is going to increase the excitability of the brain neurons. So these guys are very anxious. They have high state of excitability. They are very, very anxious. Intolerance to heat because your basal metabolic rate is high, so you're producing too much of heat. So intolerance to heat, sweating, this is what you are going to see with these guys with hyperthyroidism. Mild to extreme weight loss, varying degrees of diarrhea. The metabolic rate of all the organs have increased, so you would have diarrhea rather than constipation. Muscle weakness, extreme fatigue but inability to sleep, so they would have insomnia, and tremors in the hand. So you put their hands like this, put a paper on the top, they have very fine tremors in their hand. So they have tremors in the hand, high excitability, intolerance to heat, sweating, mild to extreme weight loss, diarrhea, inability to sleep or insomnia. These are the symptoms of the hyperthyroidism. Graves' disease, besides having hyperthyroidism, also has some specific features. One of the specific features of Graves' disease, because of this autoantibodies, is that their eyes would be bulging out. And as their eyes are bulging out, and their upper lid there is a lid lag. So the upper lid is pushed back and the eyes are bulging out. As the eyes are bulging out, the condition is called, as you can see it here, this is exophthalmos. Exophthalmos is the protrusion of the eyeballs in the people with hyperthyroidism, mainly because of the edematous swelling behind their eyeball. Retroorbital or retrobulbar edema is going to push their eyes out, and their lids would be lagged behind. So lids are not going this way, they are lagged behind. So this is called exophthalmos. How would you diagnose hyperthyroidism? By direct measurement of free thyroxine. You would also measure TSH. If you measure TSH, what would happen? It would be low. Thyroxine would be high, TSH would be low. and this is how you usually diagnose. But if you want to know if this is Graves' disease or not, you also need to measure thyroid stimulating immunoglobulin. That would tell you if this is a Graves' disease or this is hyperthyroidism because of something else. Yeah. Anybody was raising hand? Yes. Yeah, so the antibody is not only acting on the thyroid follicle, it is also acting on the retroorbital tissues where it is going to cause swelling, yeah, with fluid. Yes. 8 would? Yeah, yeah. 8 would cause eye dryness. Okay, now hypothyroidism can also happen because of an autoimmune disease. And this autoimmune disease, there are antibodies against the thyroid follicular cells. And they are going to destroy the thyroid follicular cells. And this autoimmune disease, which happens in the hypothyroidism, is called Hashimoto's thyroiditis. It is called Hashimoto's thyroiditis, where it is the antibodies basically attacking the thyroid gland and destroying the thyroid follicles, changing into a fibrous tissue that results in decreased levels of the thyroid gland. The hypertrophy of the thyroid gland, as we said, is called the thyroid goiter. It happens with endemic colloid goiter. And endemic colloid goiter is because of you have low levels of iodine in your food. So that's why you would see that most of the salt which we take is iodinized salt. Why? Because in the older ages, we did not have these iodinized salt. So there is low levels of iodine in the food. So if you don't have enough iodine in the food, this will result in deficiency of the thyroid hormones to be produced. So your TSH is produced continuously from the pituitary, which is pushing the gland to increase in size. So you have a goiter, you have enlargement of the gland, but you have less hormones. You have less thyroid hormone. So that is called the endemic colloid goiter. You have a large gland because of iodine deficiency, but you are not able to produce enough thyroid hormones. You can have an idiopathic non-toxic colloid goiter, most often associated with thyroiditis. That means there is an inflammation of the thyroid gland which resulted in destruction of the thyroid gland. So you are not able to produce thyroid hormones, but you have TSH coming in, which is pushing the growth of the thyroid gland, and that is basically idiopathic non-toxic colloid goiter. So colloid goiter is often associated with defective enzymatic system. You have deficient iodine trapping, peroxidase system has a problem, coupling of iodine has a problem, or deficiency of deiodinase enzyme. Most commonly this is because of goitrogenic substances in the dietary sources which have propylthiouracil type of properties, which can block peroxidase or iodine trapping or whatever. So how hypothyroidism patients are going to present? So you can see that hypothyroid patients would have a totally opposite type of thing. You had excitable people in with hyperthyroidism. Here there would be brain fog, confusion, because you cannot think, because you don't have enough thyroid hormone. So you have brain fog, confusion, fatigue and somnolence, extreme muscle sluggishness, slow heart rate, decreased cardiac output, because the heart rate would become slow. Sometimes there would be increased body weight. They would have constipation rather than diarrhea. They would have depressed growth of hair as well as scaliness of the skin. Edematous appearance is going to be there. So these are the characteristics of hypothyroidism, which are totally opposite to what you see in terms of the hyperthyroidism. Yes.
So Hashimoto's disease would cause hypothyroidism.
Hypothyroidism. So here, this is myxedema, which is usually associated with Hashimoto's thyroiditis. So you can see the facial swelling is there, and below the lids there is also swelling. So bagging under the eye and swelling of the face, this is called myxedema, usually associated with Hashimoto's thyroiditis. There is an increased quantities of hyaluronic acid and chondroitin sulfate bound to the protein from the excessive tissue gels in the interstitial spaces where the water starts to accumulate, and that causes the bagginess and the edematous appearance which you see here. Hypothyroid patients also have the impaired metabolism of fat, so they would have hyperlipidemia, or cholesterol levels are going to be high. They can suffer from coronary artery disease because of high levels of cholesterol and hyperlipidemia. What is going to happen in terms of diagnostic test? You would have low level of thyroxine or TGT4 and high levels of TSH. Treatment usually is for hypothyroidism is that you can give them thyroxine. So you start to give them the hormone from outside, which is thyroxine, and that's how you treat hypothyroidism. Hyperthyroidism, we have already talked about. We can give propylthiouracil and methimazole, which is going to basically block the synthesis of thyroid hormone. And if it is not treated by the drug, then you can go for surgery, which is called the subrotor thyroidectomy, which means that you can take out the thyroid gland. Now these, I'm not going to go into the whole table. You can read it yourself. This is a comparison between hypothyroidism and hyperthyroidism. This has been taken from first aid, so you can see the complete differences in different organ systems between hypothyroidism and hyperthyroidism, and some of them can be utilized for asking you some questions related to hypo and hyperthyroidism. Now, causes of goiter. So, goiter is an enlargement of the thyroid gland. So it has nothing to do with hypothyroidism or hyperthyroidism. You can have hyperthyroidism and have a goiter, and you can have a hypothyroidism and have an enlargement of the thyroid gland. There are two types of goiters, which you would a smooth diffuse goiter, which is a goiter, enlargement of thyroid gland, which is diffuse and enlarged, or you might have a nodule, which is enlarged. So it's not smooth, but it's a nodular type of goiter. So you might have smooth, diffuse, or nodular type of goiters. Now, smooth, diffuse goiters are happening because of either Graves' disease. Graves' disease is where you have the TSI, it's hyperthyroidism. You have more of thyroid stimulating immunoglobulin, and that is causing the enlargement of the gland. Hashimoto's thyroiditis, what is happening? There is destruction of the thyroid gland because of the autoantibodies. So you have high levels of TSH, and that causes the enlargement of the gland. Iodine deficiency, you have less amount of iodine in the diet, and as a result, you are not able to produce enough thyroid hormones, and there is hypothyroidism, and TSH is high, and TSH is causing the enlargement of your thyroid gland. TSH secreting pituitary adenoma. You have a tumor in the pituitary gland in thyrotropes, which is producing too much of TSH, and that causes the enlargement of the thyroid gland. So this is there. In this case, there would be hyperthyroidism. In this case, there would be hyperthyroidism. In these two cases, there would be hypothyroidism. So it doesn't matter. It does not mean that if you have a large thyroid gland, there would be hypothyroidism. It can be hyper, it can be hypo, depending upon what is causing the enlargement of the thyroid gland. If you look at the nodular types of enlargement, you can have a toxic multinodular goiter. You have multiple nodules within the thyroid gland which are excessively producing thyroid hormone, so it could be a toxic multinodular. There could be a thyroid adenoma. There could be one tumor in the thyroid gland which is producing a lot of thyroid hormone, thyroid cancer, or there might be a thyroid cyst which can all produce a nodular appearance or nodular void. Cretinism, as I said, that in children, when they are born, we check thyroid hormone because it is important for the maturation of the brain. If there is a deficiency of thyroid in the fetal life or infant life or in childhood, you have a condition which is called cretinism. In cretinism, there is mental retardation. You have, the tongue is enlarged and you have, a belly, protruded belly in the infant. So these are but the major problem with cretinism is mental retardation. So you want to avoid cretinism in all children. So at the time of birth, you check thyroxine levels of the child, because if they are low, you need to supplement thyroxine in the child because you don't want mental retardation to happen in cretinism. So what you are basically seeing in cretinism, you have mental retardation, you have relatively inhibited skeletal growth, and then soft tissue leading to enlargement of soft tissue, like leading to obesity, stocky, short appearance. Tongue becomes relatively large comparative to the skeletal tissue. So these guys are short, have a large tongue, have obesity and mental retardation. This is how the cretinism, the child of cretinism would appear. We are not going to do the parathyroid, so we are going to stop here. Thank you very much.